Great. So I'm really happy to be here today. Thank you so much for inviting me, Larry and John. I think it was lovely to just be able to speak right after this amazing talk on 7T for pathology and disease, because now I'm going to speak about applying it in vivo for neurological disease and looking some of the similar regions. Just need to declare some relationships, and wanted to mention that we have a 7T scanner, obviously, and it is the version that's magnetome, that's not Tera, but very similar parameters to what you all have. And we have an institute that's dedicated to research in biomedical engineering and imaging at Mount Sinai in New York. That is an artist rendition of our building. It looks much nicer in this versus the real life, so I put that one in. And that's like a 7T human scanner. Can you believe it? We've seen none of those today. But we do a lot of technical development. We do RF pulse design, adiabatic RF pulse design, and integration into pulse sequences for many different applications, spectro, structural, diffusion, fMRI. But I'm not going to speak about that today. I'm just going to talk about quickly some of the neurological diseases that we've applied this to. And we are in a hospital, so translation to clinical disease and working with clinical collaborators has been one of our main goals. This is just a subset of the diseases in the brain that we have applied the 7T to, but in the interest of time, I'm covering the three main ones. So we look at 7T in the skull base, which is not an easy region to image with 7T, and have applied it to epilepsy treatment. And are also looking for markers for psychiatric illness. Specifically, I'll talk about major depressive disorder. So let me start with the skull base. These are my collaborators, some neurosurgeons, some radiologists, and a handful of other really smart people. And in the skull base, we are looking at tumors, intracranial tumors that are in the bones that form the base of the skull. And they are ranging from pituitary adenomas to meningiomas, craniopharyngiomas. These are often not malignant, but can be. So they are benign, but they cause compressive symptoms such as vision loss and facial numbness, and they do grow. So removal of these tumors is difficult because they're right next to very delicate structures, vessels and nerves, that if you damage these, they will cause complications that are beyond the actual effects of the tumors themselves. So they're complex. Neurosurgery of this is complex and has been in the past been elaborative and invasive and required craniotomies. But there is an approach that is endoscopic, and this is using an endoscope that is a device that shines light into the cavity in which the surgeons need to do their resection, and it is inserted endonasally, so there's no skin incisions or any kind of, it's minimally invasive, and all of the surgery is performed through these nasal passages. Now, MRI is very, very important in this whole process to plan the surgery and to guide the surgery while it is happening, because the camera view is just a pulpy mess. Now, the neurosurgeons are able to do this even with the pulpy mess, but they really use the MRI with a CT image. They co-register it, and then they register their instruments using infrared markers that are placed on the bony anatomy, and they have a good sense of where they are because the MRI provides that soft tissue contrast, which is key to differentiate their tumors from their surrounding vascular and nervous structures. Now, 7T is a great, that's a great application for 7T because these cranial nerves are very tiny and they become very conspicuous with the T2-TSE sequence and MPRH sequence as well. This is a massive pituitary adenoma, and I'm showing it not because it's hard to see this tumor, obviously you can see this at 3T, but because it compresses those nerves, that optic chiasm and the vessels around it quite significantly, and only in 7T can you see these smooshed structures. I don't know if that's a very scientific word, but they're smooshed by the tumor. And the tumor itself has areas of heterogeneity within it, firm and soft areas, very important for the surgeons in trying to plan their surgery. And these are depicted quite nicely with the resolution at 7 Tesla. The time of flight angiography sequence that operates much more effectively with these longer T1s at 7 Tesla actually really helps with the depiction of the branches of the arteries feeding the brain. The tinier branches of the internal carotid artery, these become more visible because naturally the tagging is more effective. So we overlay these time of flight images, time of flight vessels on top of the tumor. This is a meningioma, and it is depicted by the white asterisk on the right, and the vessels that surround it, the branches of the carotid arteries, are shown in a heat map on top of it. And this actually is very useful for planning and also for guidance in the operating room. Some of the decisions that are made are using many different factors. They synthesize a lot of information. And I had the opportunity to observe one of these surgeries, and the decision-making process is greatly enhanced by having some information of the relative location of these structures geometrically to each other. We have also performed for the first time dynamic contrast enhanced imaging for these skull-based lesions. And it worked effectively to delineate, and here is shown with a white arrow, the area of the pituitary gland that's tumor versus normal pituitary gland. And we're exploring this because in any kind of tumor protocol, contrast has to be actually included. So if we want to use 7T for tumor imaging, skull-based tumor imaging, but also moving on to malignancies, exploration of contrast is important. So we've put this into practice. We've worked with our neurosurgeons to basically use these for planning, but also to depict them, or display them on the neuronavigation screen. So we work with those vendors as well. And overall, we've reported, at least for detection of cranial nerves and branches of the arteries in the tumor patients that we've studied, a significant improvement. And we've come up with quantitative scales to actually assess this, and reported these results and published these results. Oh, this does not look like what it looked like in my, that's pretty, but that's not what I was planning to show. Something went a little wrong when I put the thing on here. But anyway, that's supposed to show the optic radiations, and is not supposed to be something that you would like to look at while on some types of drugs. But anyway, it's reminding me of that Space Odyssey movie, 2001. I don't know if people watch that. It's a really good movie. So this is actually a slide showing that beyond looking at the utility of 7T for treatment and planning, we also looked at markers for damage to pathways due to these lesions. No one really actually has explored this in the past. They know that these lesions are causing symptoms in that moment due to compressive, compressing against certain structures. But we found that in assessing the entire optic apparatus, this is work by Jack Rutland, when you look at the thickness of the optic chiasm through the structural imaging and assess quantitatively, obviously, the cortical thickness of the visual cortex, but also look at the diffusion tractography of the optic tracts and the radiations, and look at the FA and MD along those tracks. There is actually, oh, no, all my graphs are gone too. I hope that the rest is good. Okay, sorry, these show that there is actually, not this right here, but I was planning to show that there is actually damage to these tracks. The FA is reduced in patients versus controls, and the MD is increased. And we looked at several points along the optic tracks. All right, I think that moving forward, we're good. No, we aren't. Let's see. Okay, some of them are good, some of them are not good. Sorry, guys. This is also messed up. But in the skull base, there's another type of condition called trigeminal neuralgia. And this is a condition where there's shocking facial pain caused by some sort of damage to the trigeminal nerve, which is it's one of the main cranial nerves that's emerging from the brainstem and innervating the area of the face. So, so basically what happens is that the etiology of this is often not very well known. The source of the pain could be caused from anything. A vessel could be impinging upon the nerve. That's often the case, and there's a treatment for this, but then there's other issues as well, multiple sclerosis, just kind of nerve damage, demyelination, any kind of injury. And this is a place where the 7T could actually really be helpful in depicting these intricate structures more effectively and showing the offending vessel that is actually pushing upon the nerve. So we are doing this for, again, helping make treatment decisions and integration into surgical efficacy, but we also are looking at damage to the rest of the circuits in the brain when people suffer from such a condition. So here, it was explored by Jack Rutland again. What is the difference on the affected side of these patients who have this chronic facial pain due to the trigeminal nerve of tracts that connect the thalamus to the somatosensory cortex? So it was found when looking at group differences between these two groups, the controls and patients with trigeminal neuralgia, that on the affected side, there was indeed a reduction in FA and an increase in mean diffusivity along those specific spinothalamic tracts. So very interesting finding. And again, an understudied condition and often misdiagnosed, but so painful that it's known to be the suicide disease. So in the skull base, we're exploring all of these things. We're looking at these intricate structures, and I think it's a good application of the 7 Tesla. We are also applying it to epilepsy treatment. We have been looking at 7 Tesla in epilepsy for since I've been at Sinai, and so it's been a little more than 7 years. Epilepsy, I think, is a really good application for this, and I know other sites are also exploring this and using this. In epilepsy, there are 40%, so we know that it affects a lot of people in the world, 50 million people worldwide, but there's 40% of these patients who fail to respond to drug therapy, so this is drug-resistant epilepsy. In these drug-resistant epilepsy patients, there are several different treatment options, such as surgical, resective surgery, so resecting a part of the brain that may be the focus of the seizure. But also now there are all of these minimally invasive options, such as responsive neurostimulation and laser ablation. So inserting electrodes to modulate neural activity in patients where we're not 100% sure that resecting tissue would actually be the most effective strategy. MRI is very crucial in making these decisions, where to place the electrodes, what part of the brain to resect. And when you don't have a clear abnormality on MRI, when you're MRI normal with the clinical exam, there is a substantially reduced chance of surgical success of reducing seizure burden than if you do have a clear abnormality that is found. Now, because of the fact that epilepsy can be caused by many different types of abnormalities. These are developmental abnormalities in the cortical gray matter, hippocampal abnormalities, some sort of TBI or lesions, tumors, vascular malformations. Doing a multimodal exam at 7 Tesla, actually with looking at for very subtle abnormalities that may have gone undetected in the clinical exam is actually important as a non-invasive diagnostic option for these patients. And here's just a chart showing what kinds of abnormalities can be detected using these multimodal exams. We actually applied some of the structural imaging sequences that we've heard about today, in addition to SWI, or susceptibility weighted imaging. We did include, in addition to this, eventually diffusion MRI and functional MRI, as well as spectroscopy or spectroscopic imaging. But I'm showing some results from the structural imaging that we performed on 37 patients who were MRI normal. So these are drug-resistant epilepsy patients who were MRI normal at 3 Tesla and 1.5 Tesla. Actually, there were a mixture of 1.5 and 3 for their diagnostic exams. And we basically enrolled them in the 7T study and found in many of these patients an abnormality that appeared on the 7T. This is a hippocampal abnormality in the left hippocampus. We also found a polymicrogyria, which is a thickening or appearance of cauliflower appearance in the gray matter. And it had gone undetected at 3T, although I'm showing the 3T here, it does show a little bit of thickening in that area. But it was very conspicuous using FP2 RAGE as well as T2 TSE. And there was an underlying vascular abnormality in the SWI image. We found the SWI images did provide some information that would be useful for inspection of the T2 weighted images to look for cortical defects. And then here's another case where a dysplasia was found in the gray-white matter boundary. And this was, again, in both of these patients, resection was performed after looking at the diagnostic scans and also the clinical symptoms. And these people were basically seizure-free after their surgery. So overall, we found many more abnormalities of clinical significance in our non-lesional epilepsy patients than we did in healthy controls. And we wanted to look at them in comparison with healthy controls because we don't want to just look at abnormalities because they're above the threshold of detectability and they could be possibly non-clinically significant. And out of these 37 patients, we found epileptogenic potential abnormalities in 25 at 7T, and 15 of these co-localized with what was the suspected area of the brain involved in the epilepsy. And 7 of these actually contributed directly to change surgical intervention, of course, with conjunction looking at the other clinical data. So epilepsy is a network disease, and therefore we want to look at some of the other nodes that are involved in this network, this abnormal network. And we can do this by applying more diffusion and fMRI techniques to our entire epilepsy neurological protocol. And we are doing that and basically doing connectivity measures and looking at both the diffusion of fMRI, computing the connectivity matrices, and also doing graph theory analysis. In addition to that, we're kind of combining areas of the brain that appear abnormal in the structural imaging as well as the functional imaging. And if there are a few standard deviations away from our group of normals, we create something called the abnormality index that basically integrates all of these multiple modalities of data and provides something to the clinicians to determine whether or not to re-inspect that area, basically. And so we have integrated it into surgical treatment with a lot of thought, put a lot of thought into this, and basically do provide a within subject control where we'll integrate the 7T data into the clinical case conference only after assessing everything with the clinical diagnostic scans at lower field strengths, and then recording the changes that happen in the treatment plan due to the introduction of the 7T data. And some of the advantages of 7T data is to try and explore more minimally invasive options, such as the implantation of minimally invasive stereo EEG leads. These allow us to validate that these are indeed involved in the seizure network, these areas are involved in the seizure network, and maybe place more dense leads in areas that we think are more highly suspected. We did look at other markers of epilepsy, so subfield volumetrics were performed in the hippocampus, and in these non-lesional patient data, we found more asymmetry in these subfields, including the CA1, CA2-3, and dentate gyrus and subiculum in patients with suspected medial temporal lobe epilepsy, mesial temporal lobe epilepsy when compared to the controls, and it also correlated with the duration of the disease. We were able to look at tracks that are subfield specific, and that's an interesting diffusion innovation we can do because we have higher resolution data with the structural and the diffusion, and found differences in the tractography for epilepsy in the dentate gyrus, the tract density for the dentate gyrus for the epilepsy patients versus the controlled. So you know what, because I'm running out of time, I'll just quickly let you know that there's other markers we found as well, like perivascular spaces being different. And the next area that I wanted to shift gears to is depression. And it's a very different thing. We're not looking at it, this is the treatment of depression, but rather understanding the pathophysiology of it, because it's very complicated and we really don't know the pathophysiology of depression. These markers could help us illuminate that. So we threw the battery of tests on a set of patients, 35 patients now, and have found an amygdala subnuclei correlation with depression severity. And these are all corrected for multiple comparisons, and have also found differences in the connectivity of specific subfields of the hippocampus for the depressed patients versus controls. And we have done amygdala subnuclei connectivity as well, and found so this is the total connectivity of the amygdala, but these are specific subfields of subnuclei of the amygdala. We're able to do subnuclei specific connectivity, and found that the amygdala subnuclei and the right amygdala subnuclei, some of them are hyperconnected for patients with depression versus controls. And we've also performed graph theory analysis and found that some graph theory metrics relating to the precuneus are very much correlated to the rumination score, which is the symptoms. We've done cognitive measures for each symptom of depression for all of these patients, and we found that there's a strong correlation between these graph theory metrics relating to the specific region of the brain and rumination. So that's it. Thank you very much for this very quick overview, or, well, I guess I did go over time. But yeah, so that's some of the work we're doing, and we're working in some other diseases as well. Thanks.